We'll get started in a second, just as people are joining. Great. Well, welcome everyone to MGB Combined's Global Health Rounds today. My name is Dr. Joe Radigan. I'm the Chief of the Division of Global Health Equity at Brigham and Women's Hospital, and I'm delighted to introduce our speakers today. Our first speaker is Dr. Sunil Solomon, who's a professor of medicine and epidemiology at the Johns Hopkins University School of Medicine. Dr. Solomon completed his medical training at Sri Ramachandra Medical University in Chennai, India, and received a doctorate in epidemiology from Johns Hopkins University Bloomberg School of Public Health. His research is focused on the epidemiology, prevention, and care for people who use drugs and men who have sex with men. His team established among the first comprehensive HIV centers for people who use drugs and the trans community in India. He has published widely on this topic, and in April 2019, he was awarded a $50 million cooperative grant from PEPFAR to implement and evaluate innovative models of service delivery to improve HIV care, the HIV care cascade in India, with a focus on vulnerable populations. Dr. Solomon is joined today by Mr. Sri Krishnan, the Chief Operating Officer at YRG Center for AIDS Research and Education, who works on implementation activities across 27 cities in India. They are also joined by our own Dr. Lakshmi Ganapathy, a pediatric infectious disease specialist at the MGH and HMS, and a physician educator, investigator at the MGH Division for Pediatric Global Health. Dr. Ganapathy works with the YRG Center on HIV, hepatitis C, and substance use disorders among young adults. We are excited to hear them present today on lessons from the field, a 20-year journey with people who inject drugs in India. Thank you.
Thank you for that introduction, Joe, and thank you again for the invitation to present here today. I'm hoping you can all see my slides. So what I'm going to do over the next 30 minutes is just take you through my journey of why public health and how I got in here and what are the key lessons that I've learned from the field. And then while most of it is going to be focused on HIV, I think these lessons are translatable to pretty much any disease, communicable or non-communicable, in the global health arena. This is the disclosure summary accreditation statement with the SMS code for those of you who are attending for credit. So I just wanted to start by giving you a sense of how I got into public health. So my father actually was one of the people who was working with Dr. DeBakey and Cooley on stenting studies, the preclinical studies of stents. And so when I was growing up and I was in medical college, I really wanted to be a cardiothoracic surgeon. He started cardiothoracic surgery in India, in South India, in Chennai. So all through my residency and my training, I was helping him out and I was operating with him. And eventually, when I was done with medicine, I was like, what do I do with my life? I really want to be a cardiothoracic surgeon. But by that point in my dad's career, he was sort of moving more to the public health field versus cardiothoracic surgery. And I asked him, why surgery? Why are you moving to public health? What's going on? And so his advice to me, which is what I really drove me into public health, was before someone requires cardiothoracic surgery, it's just too late. And if you're looking at the most vulnerable populations, they really can't afford it. Many of them sell their houses, sell jewelry, and then they don't end up living too much longer, and then the debt is transferred onto the family. And so he said, if you really want to make an impact in the world, you really have to focus on public health and focus on prevention. And so that really is like the first lesson I learned in the field is in global health, prevention is the currency. If you want to make an impact, we really have to focus on preventing disease. And this is not necessarily only for infectious diseases, but it also translates to non-communicable diseases like early diagnosis of diabetes or hypertension. And even in cancer, if you can't prevent it, at least if you can diagnose it early, there are strategies you can take. So I would say like prevention probably is the key. And there are many vaccine preventable diseases like hepatitis B, where we still haven't done a great job of eliminating it despite the presence of at least one or two efficacious vaccines. So I would say like this probably is like the most important lesson I've learned is without prevention, you really can't go anywhere. So following that, I did my master's in public health in Baltimore at Johns Hopkins, and it's impossible to go to Baltimore in the public health program at Johns Hopkins and not hear about the Alive cohort or the Max cohort, and drug use is just in your face when you're in Baltimore. So when I went back to India in 2004, my mother was running one of the largest HIV private clinics in Chennai in the state of Tamil Nadu. So I worked in the clinic and I was seeing a lot of heterosexual populations, but I wasn't seeing people who inject drugs, which really sparked my interest. Why are we not seeing people who inject drugs in this particular clinic? And I think what I realized was the clinic was in the southern end of Chennai versus people who inject drugs lived in the northern end of Chennai. And so it really was a challenge. I think it's only 10 miles, but in India, those of you who've been know like 10 miles can be an hour or it can be 2 hours, depending on what the traffic looks like. And so we actually established a facility in the northern end of Chennai, and we built a longitudinal cohort of 1,200 people who inject drugs in Chennai. So this came off an administrative supplement, which was like $100,000 from Carl Latkin and David Chalentano from Hopkins. And so the other thing you also learn in resource limited settings is $100,000 can go a long way. It's probably impossible to establish a cohort of 1,200 people anywhere in the US for anything less than $10 million. That's pretty much the scale of things. So we established this cohort in Chennai, and it really was trying to replicate what was being done in Alive. And what we noticed was there was an extremely high burden of HIV, hepatitis C, and hepatitis B in this population. And we kept referring people to government facilities for care. I'm talking about 2004. And one of our participants actually came back and told me, listen, I went to the hospital with my sister. The doctor looked at the sister and said, your brother's a drug user. He's going to die. Why are you bringing him here? And so that really upset me because I felt like we were finding people with infection, but there was nothing we could do for them. And so we actually established a clinic at the same site where we were running this cohort. Ramnath, who was actually Lakshmi's husband, was and also a resident at MGH, was a Fogarty Ellison fellow. So he was the one person who used to go with me to this clinic. We used to go every Saturday, sit there, examine all the patients who were walking into this clinic. And over time, what happened was they realized that we weren't really judging them for anything. We learned a lot. For example, a lot of the patients used to smoke marijuana in the clinics and outside the clinic, and the smoke used to come into the clinic. But then we realized like if you want to work with these communities, you can't judge them and you can't tell them do this and do that, because you need to work with them to realize this is the circumstances in which they live. And so that's pretty much how we built the clinic. And over time, they started bringing in their wives, children, and other people with similar issues. And most of the medications we were able to get was like by talking to pharmaceutical companies who donated free samples. And we were really focused on management of opportunistic infections, because I always believe that if you are giving them lifelong treatment, then you ensure that you have access to lifelong treatment and it doesn't stop when a project ends or a grant ends or a donation ends. And so we were always referring them to the government facilities for antiretroviral therapy. But what we noticed between 2006 and 2008, so this was the era of generic antiretroviral therapy. PEPFAR had launched their programs globally. India had like a free rollout program from 2004. And so the ART centers were probably about a mile from where this clinic was. But despite that, while we were heralding the era of generic antiretroviral therapy and having all these reports of reductions in mortality and heterosexual populations and populations in Africa, in this population in 2006, 7, and 8, the mortality, especially among those with a CD4 less than 200, was 35 per 100 person years. And this just was completely unacceptable. And this was almost 3 times higher than what the mortality was among people who inject drugs in the Alive cohort in the 1980s, when we had no access to antiretroviral therapy. So this really brings me to the second lesson we learned is, if you want to solve a problem, whether it's ending the HIV epidemic or eliminating hepatitis, we always need to ask the hard questions. We tend to pick the easier questions. For example, if you're looking at the studies, the licensing trials for long-acting antiretroviral therapy, we essentially took people who were virologically suppressed and said, can we give them a better therapy to keep them virologically suppressed? Right? We're not asking the question like, how do we get people who are not virologically suppressed? And the same thing applies to long-acting antiretroviral therapy, where we took populations that all long-acting PrEP, where we took populations that already had efficacious PrEP options and found something even better, versus people who are injecting drugs or active people who are injecting drugs who really have no PrEP options at all. There have been no trials conducted. And so if we are serious, then what we need to be doing is asking the questions that are harder to answer and designing studies to answer these questions, because that's the only way we are going to reach elimination or end the HIV epidemic or whatever the ambitious elimination agenda is. So why was mortality really high in this cohort? And so we spoke to a lot of the patients who were being referred to the antiretroviral therapy centers, and we asked them, why are you not going? What's happening? And their primary complaints were, when we go there, it's a long wait time, and most of us are daily wage earners. If we go there and we wait in line, then we lose our daily wages, and this impacts our ability to buy food, so there's no food for the families. And so it really was a multiple levels of issues that were preventing them from accessing antiretroviral therapy. And so we implemented a trial of contingency management where we essentially gave them non-monetary incentives. So we gave them like rice, dal, soap, toothpaste, shampoo bottles, and each of these had a particular value. And every time they met an outcome, it was going to the antiretroviral therapy center, initiating antiretroviral therapy, picking up their refills. They earned a particular value, and that value could be redeemed for any of these items. And the way we designed it was to really offset the opportunity cost of time that these people would need to spend going to the antiretroviral therapy center, waiting in line, picking up the medicines, and coming back home. So what we found, this is probably one of the earlier studies of looking at contingency management on antiretroviral therapy, we found that contingency management increased the initiation of ART by almost threefold increase. Right? But I think what was really striking to me was the engagement of the families, because we were giving them soap and dal and rice and nutrition, which was useful for the entire family. We heard from a lot of the wives and the mothers, thank you for doing this. It's giving us, because previously we weren't sure where the money was going, but now we're actually getting stuff coming home. And this is really helping with nutrition for the child, helping with nutrition for the family. And so the family was a lot more engaged in pushing people to go pick up the medicines, pick up their refills. And so, which brings me to the third lesson that we learned is listen to the people, right? Because I think the communities that we're working with know best what solutions are going to work for them. Very often we sit in our offices, in our ivory towers or wherever it is, thinking we know what works for the community. But each community in each part of the world, and sometimes even in different parts of a state, are completely different. So when you're developing a program for global health, go out there, talk to them, walk with them, and see their lives, because that's the only way you're going to, and ask them. Like, honestly, I think if we can ask them what will work and develop interventions based on what they tell us, that really will make a lasting impact on these communities. But we were working in Chennai, and I think for those of you who are aware, India has like a very unique position. We are right between the two largest heroin producing regions in the world. So to the right of India on the map is like Myanmar, Laos, and Vietnam, which is the Golden Triangle, which has historically been one of the largest heroin producing regions in the world. And to the left of India is like the Afghanistan, Pakistan area, which is the Golden Crescent, which is currently the largest heroin producing region in the world. And so between these two areas, we have drug trafficking routes running through India from both the northwest and the northeast. And as you can see from this map, it passes through India. A lot of it is used, some of it is used in India, but from India, it goes to other parts of the world as well. So, and India also is like home to about 6 million opioid users, which is the largest in the world. But for those of you who are familiar with India, with 1.4 billion people, we're the largest number of a lot of things in the world. And according to the most recent estimates that we have, there are about 850,000 people who inject drugs spread across India. And so we realized that if we wanted to make an impact on the drug use epidemic in India and impact lives of people who injected drugs, we needed to expand outside of Chennai. So what we ended up doing was pretty ambitious at that point in time. So this was, again, the studies were written in 2012. They started in 2010. We initiated the trial in 2012. And it really was looking at the impact of integrated delivery of HIV prevention and treatment services in a non-discriminatory and a very PVID or MSM-friendly setting. But our primary outcome was really looking at the improvement in HIV testing uptake among people who inject drugs and men who have sex with men in India. You can see we were all over the map. Most of the PVID sites were in North India and in Northeast India, and most of the MSM sites were in the South India and one site in Central India in the state of Madhya Pradesh in Bhopal. So the way we designed this trial was we did a baseline assessment, which was respondent-driven sampling in 27 cities. And from these 27 cities, we selected 22. And then we randomized them, 11 to get the integrated care centers and 11 to get usual care. And then we followed them for 2 years and did another evaluation in the intervention and the control clusters. And so the way we looked at the outcome was we had a snapshot of what it looked like at the community level at baseline, and then we had another snapshot of what it looked like in the intervention and community sites, intervention and control sites at the community level 2 years after the implementation of integrated care centers. So just to be clear, these integrated care centers provided did not follow any cohort. We were rather looking at like the community level impact of integrating these integrated care centers. So the way we designed it was really around the UNODC and UNAIDS models of what they were recommending at that point in time. So really the crux was HIV testing in a person-centered manner where all the different HIV prevention and treatment services required for an individual were available within the facility itself, or we provided a referral. So the only thing we weren't able to provide within the facility was antiretroviral therapy, where we had case managers walk them or take them to the antiretroviral therapy center to get them initiated on ART. We had TB screening, sexually transmitted infections. We also introduced viral hepatitis screening, especially for hepatitis C after the advent of generic DAA. So that was in 2016 when these clinics were running. We implemented hepatitis C testing as well to see how does hepatitis C testing work within an HIV model. Obviously, for people who inject drugs, we had harm reduction services, and we also provided general medical care. And over the course of the trial, we provided, each of these integrated care centers provided services for about 2,000 people who inject drugs, the PVID centers, and then the MSM centers provided services for about 1,000 to 1,500 MSM in each of these clinics that we established. And what we really found was we did improve testing. So the way you look at this map is like the green arrows going up are a good thing, the red arrows going down are a bad thing. On the right, you have the integrated care center sites. On the left, you have the usual care sites. So overall, you can see on the right, most of the lines are green, except in Dimapur and Aizawl, where it goes down. And again, this is a challenge of doing serial cross-sectional surveys because you're no longer following a cohort, but you're seeing what's happening at the community at that particular point in time. So overall, we did see a 31% increase in recent HIV testing, which was defined as HIV testing in the prior 6 months, in the intervention sites versus the control sites. But many of us, I think most of us, are obsessed with the p-value. So the p-value is 0.09, and so it was deemed not statistically significant, right? But I think that's where we need to distinguish statistical significance versus significance and impact. Because over the course of this trial, we provided HIV testing and other services to almost 65, 70,000 people who inject drugs and MSM, right? To me, that is a significant impact. Yes, it failed to meet statistical significance, but it really did improve access to testing and care for populations that were previously being left out of these populations. And for those of you who are interested in designing cluster randomized trials, I have a lot to tell you about and to discourage you from ever doing a cluster randomized trial, especially with a limited number of clusters, because the heterogeneity between clusters can really impact your power and your sample size and everything else. And then what we also didn't realize when we did the study was we were very naive to think that one clinic in Delhi was going to serve all the people who inject drugs in Delhi, right? And so you can see on the graph in the right, the dotted line that's going up. And so what it shows you is like the proportion of people who are going to the ICC representing a subset of the total proportion of people who inject drugs in that particular city. So the more people in the city we were reaching, the higher was the impact of recent testing. So essentially, it shows you that if you are planning something like this, you need to think about the population size before you do it. And the greater the population size, have more clinics. So you make sure that you cover more of the population, and that way you probably will have impact. While this didn't meet statistical significance, the one good thing that we did was we partnered with the National AIDS Control Organization, the state AIDS control societies. This was funded by the NIH with co-funding from the Elton John AIDS Foundation. And so because the government was involved right from the beginning, and this was in 2012 when people were still not talking a lot about integrated care models for HIV, it really did spark the government's interest. And we released a technical brief in 2019 or 2020, which was in collaboration with the government. And right now, the government of India is actually starting these things called one-stop centers. I think there are 71 of these across India, targeting people who inject drugs and the trans community. So though this trial failed to meet statistical significance, it somehow sparked interest in the government. And now we have like access to this, like a light version of these ICCs, or the one-stop centers, which are across the country, improving access to people, improving access for HIV testing and care to people who inject drugs across the country. And so that becomes the next lesson is we can do these trials and impact like in a small population and show you what works, what doesn't work. But if we really want to impact at the community level and at the national level, we have to start engaging the government right from the get-go. Like we had them engaged in the way we selected sites. For example, Kanpur in Uttar Pradesh, where Christian currently is, was something that was recommended by the government. There was no data on people who inject drugs when we went here. And so it came from the government. And so they were vested in this trial to see how it worked and how do you actually grow from there. So for everyone who's doing anything in global health, working with the government right from the start, making them a partner, getting their inputs along the way is going to be critical for not just sustainability, but also scalability of the intervention. But despite the success, India, like I told you, is like a very heterogeneous epidemic. For example, if you look at the two sites with the highest HIV prevalence, which is Delhi, which is the red big circle in the middle, I'm not sure if you can see the 38, and then you can see Imphal, which is a 32.2 in the northeastern state, the incidence is completely different, right? Like in Delhi, it's 18.5 per 100 person year. So this is cross-sectional incidence using a recency assay versus in Imphal, where the incidence is 0. And what was really different about these two cities was in Imphal, we had the highest levels of viral suppression among people who inject drugs in 2017. Actually, in 2017, Imphal was the one city in India that had already passed the 90-90-90 threshold for viral suppression among people who inject drugs. But in Delhi, despite free antiretroviral therapy and almost like 7 or 8 different antiretroviral therapy centers in New Delhi, we still saw an extremely high incidence, which really begged the question of, why are we seeing such a high incidence? And so we established a longitudinal cohort of people who inject drugs in New Delhi in 2017. And it really was to try to understand incidence. What was driving incidence? Was it egocentric networks, social networks, sociometric networks, spatial networks? Because if we can figure out what is driving incidence, then it gives us a point to intervene. And for those of you who are not familiar, I'll walk you through these networks very quickly. So an egocentric network is basically just the index with everybody that he or she is directly connected to. A sociometric network is the index, their first level of the first degree of contacts, but also the contacts of that first degree of contact. So their first, second, and third degree alters become part of their larger network. Because it may be easy to assume that the egocentric network is the risk network, but unfortunately, if a third degree alter is infected with HIV, that still places the index at risk because of the chain through which they could get infected from that third degree alter. So if you take that a little bit further, is the socio-spatial network, which not only takes like individual connections, but also looks at connections with space. So you can see like the first degree spatial hotspot for that particular index is everybody who's connected to the same hotspot the index is injecting in. Despite that one individual not being part of his egocentric network, he still is connected to that person through a by the spatial network. But all these individuals, though they're part of different networks, they all have these multiple connections, both through individuals and through spaces. And this was something I was really interested in, because if you look at people who inject drugs, it's like we always assume that it's it's the risk network, and risk networks are stable over time. And that's pretty much how most of the network studies have been designed, where you recruit the egocentric network and follow them over time and look for outcomes. But I was convinced that if I was injecting with somebody and I went to the same place that I injected and that person was not there, it's not that I'm not going to inject, right? I'm going to look for someone else who's there whom I can share my needles with and or share my drugs with, because it really is a social experience, drug use in India, where someone brings the needles, someone brings the drug, someone brings the cotton or the other things that you would need, and then they mix everything together, and all two or three of them inject together. So very rarely injection happens alone. And so I was interested in, like, what was the role of space and the access to different harm reduction services, HIV testing, and antiretroviral therapy in these spaces that was driving HIV risk. And the more complex version of that is the last one on the right. So what I want to really point out here is, like, if you didn't have spaces, these would be considered as two separate networks, one with index 1 and all those individuals over there, and the second with index 2 and all these individuals over here. So you would assume that those two social metric networks are independent of each other. But the minute you throw space into the equation and look at overlapping spaces where people inject, it all just merges into one large network. So these kinds of studies are rare because they're hard to do. There are one or two studies that exist, and most of those that do exist are cross-sectional without following people longitudinally. So what we essentially did was we recruited networks of people who injected drugs. We started with 10 index participants, recruited their active injection network, which is people whom they had injected with in the prior 1 month. And then those network members served as the next wave of index participants. But what we also did was every 6 months, we kept asking them, are you still injecting with the same person? Are you still injecting in the same place? Are you injecting with a different person? Are you injecting in a different place? So that way we were able to look at in-migration and out-migration, both in people and places over time, because that gives you a sense of, especially if you're looking at hepatitis C, where we talk about the treat a friend or the network-based treatment approach. What is that relevant network that we should be treating? Because if there is a large network turnover, then the concept of the network gets a lot more complicated than our primitive understanding of, like, you inject, A injects with B and C, so A, B, and C form a network. So that really was what we were trying to understand. So we initiated a recruitment with 10 indexes, all of them are male, which is consistent with what the PIVOT epidemic looks like in New Delhi. We recruited 2,512 people between November 2017 and July 2019. And Christian can definitely tell you a lot more about that in the panel on how we actually do this. There were only 20 cisgender women and 3 transgender women. And this is, again, consistent with what the drug use epidemic looks like in most of North and Central India. In the northeastern states of India, we see a significant number of women who are injecting drugs. About 10 to 20% of people who inject drugs in the northeastern states of India are women. And the median number of coupons that were handed out were 1, so which generally tells you that each person has a network size of about 2, but it goes anywhere from 1 all the way through 7. Right. And for a network study, 75% of coupons being returned is actually extremely high if you compare that to network studies everywhere else. But I think what really struck us was, like, the baseline disease prevalence. So HIV prevalence was 37%, and 93% of them had detectable HIV RNA, which essentially meant that the majority of the people had transmission potential in this cohort. And what was also striking was the hepatitis C antibody prevalence. Again, it shouldn't be surprising because there really was no access to care in this population. But then we looked at the network structure. So this is not using spaces, it's just using individuals. You can see that despite starting with 10 indexes, 6 of those indexes merged into this one large network in the middle, right? And starting with that big circle in the middle, which was like the first index participant who was really connected to multiple people, despite bringing in only 2 or 3 people as part of his injection network. He was connected to multiple people across. And so it really shows you how complicated networks are among people who inject drugs. You cannot do a very simple study to look at treatment as prevention, for example. Let's just recruit them and then see what happens over time. But it gets a lot more complicated. And you can see there are 4 other networks. I don't know if you can see them. There's one over here, one in the bottom, one here, and there's one individual who never recruited. But what I also want to point out is the number of red circles you see here. So we saw 159 seroconversions over about 730 person years of follow-up, resulting in an HIV incidence of 21 per 100 person years in 2020 in a population in a country with free access, actually making antiretroviral therapy for the rest of the world. We have like 7 ART centers in this particular city, and still almost no one was virologically suppressed, and the incidence is probably the highest anywhere in the world at this point in time. But what was also interesting is if you look at the networks a different way and look for clustering by space, you can see that the prevalence is not evenly distributed across the city of Delhi. There are those clusters right in the middle where there's a lot of infection. Right? And so that really translates into our predictors of HIV incidence. So we look at all the usual individual level factors like age, sexual activity, injection sharing, injection frequency. Yes, they were all associated with injection drug use, but with HIV incidence. But I think what was really striking and has rarely been documented before is this role of space. Like one particular venue number 40, was associated with almost a 3 times higher likelihood of seroconverting. And similarly, the further you were from venue number 40, either directly injecting or through your network partners, your risk of HIV seroconversion reduced, right? Suggesting that space may have a lot more to do with HIV transmission, because space is a proxy for undocumented network connections. For example, if I ask someone, who did you inject with in the past 1 month, you may remember the names of the 1 or 2 people you injected with in the past week, but you may have forgotten someone you injected with 4 weeks ago. And I think what space actually does is it pulls all these people into the same network. And so I think space actually is a proxy for both the documented and the undocumented connections. And just to give you a sense of how complicated these networks are over time, so each of these purple spots represents a space, like a particular venue in New Delhi where people reported injecting drugs. And what this shows you is the evolution of the network over time. The pink circles represent the individuals with prevalent HIV infection who have detectable HIV viremia. The red circles are the ones who are incident HIV infections. And then the white ones are either negative or the ones who have undetectable HIV RNA, which basically means that they probably are unlikely to be transmitting. And what I really want to show you is how complex these networks are. On average, there was 75% network turnover in terms of individuals, and each participant reported a network turnover of about 1.5 partners per year. So it shows you that network-based strategies among people who inject drugs, at least in New Delhi, is complicated. Like we haven't repeated these studies in other parts of India or in other parts of the world. And they did do a smaller study in Australia, which also documented that there was a large amount of network turnover. They didn't look at spaces, they looked at networks. But I think building in the space into these different equations really is something we should be looking at going forward. And what I also learned through this process, like we were using our primitive epidemiological methods, but to do these analyses, I started working with Stephen Clipman, who is trained in bioinformatics and a PhD from the Global Disease and Epidemiological Control Program at Hopkins. And so he brought in deep learning, graph neural networks, and all these different methods that we use in data science to try and use all the data that we have. And so it really shows you the value of building interdisciplinary teams. And we also brought in virologists because we're currently sequencing all the virus in both HIV and hepatitis C in this cohort to try and see what do sequences tell us about networks versus people versus places. But I think what was really striking was 113 of these incident infections reported injecting at one venue, which is venue number 40. Right? So this really suggests that you could potentially interrupt the HIV epidemic in New Delhi by focusing on that one particular venue number 40. And if you could flood that with harm reduction, HIV prevention, and HIV treatment services, and reduce the proportion of people with detectable HIV RNA or increase the level of viral suppression there, you probably will interrupt transmission everywhere else in New Delhi. And so I guess that the next lesson I learned was if you see something that is interesting and piques your interest, go after it. Right? So when I saw that high HIV incidence, I was very interested in understanding why. And what that led me to do is like build these interdisciplinary teams and build these new models. And there are a lot of people who are using this cohort now to answer other questions about the role of network position in terms of access to HIV prevention and access to care. There's someone else from Hopkins with another grant looking at other viruses like the viruses and their role in prediction of HIV transmission. But that being said, what was also interesting was when we were doing this cohort, we also had another trial running in New Delhi among people who inject drugs, not too far from venue number 40. Right. And so this trial was again looking at voucher incentives, trying to replicate what we had in Chennai in New Delhi, and trying to see, can we have that same impact in New Delhi? So we had to stop the trial at month 12 because it started recruitment about 2019. And then when the COVID pandemic hit, all research halted. And if you look at viral suppression in this cohort, we barely scratched 10%. Right. And this was despite providing incentives for people to go to antiretroviral therapy centers, pick up their medications. There were significant incentives being provided for each of these outcomes. But in New Delhi, this was probably the site with the poorest viral suppression rates across the entire trial. And shows us that despite all these different efforts we were taking, we just weren't making an impact in this population. So we actually went to venue number 40 to see what it looks like. And what we saw was like this blue shed that was at the venue. But what was striking was on the other side of the blue shed, we saw a lot of people, right? And all of them were injecting with each other. On average, there were about 300 to 400 people transitioning through this one particular area every day. The mortality among people in this area was about 30 per 100 person years. There's extremely poor access to antiretroviral therapy. And this is also striking because there was an opioid substitution therapy center less than 50 meters from where this particular blue shed was. And yet we were seeing this extremely high incidence. So when we spoke to them, they essentially told us, we have all moved to Delhi in search of a job. We are not able to find a job. We have no access to food. We have no access to showers. We have no access to toilets. And you want us to go and get tested for HIV. And I think that's the thing we always forget is like we go with things from such a disease-centric perspective that we always forget about the person. Right. And I think it's important for us. And I think COVID brought this out a lot more with the socio-structural determinants, but these exist in every disease. And so when we're focusing on diagnostics and biomedical interventions, I think it's equally important to start focusing on housing, unemployment, incarceration. And this is the only way we are going to address disease as a whole and transition from a really disease-centric perspective to a very person-centric perspective. And that really is like the biggest lesson I've learned from everything I've done on the field so far is like we need to transition to disease, to person-centric perspectives. And this is not just with people who inject drugs. For example, during COVID, we were doing home delivery of antiretroviral therapy to almost 18,000 home deliveries across India. And I think the one thing we got from many of the parents of children where thank you for giving us antiretroviral therapy for our child. We have lost our job. We have no money. There is no food. So who's going to support food for these children? Right. So I think it's important for us to step back and when we're saying people who inject drugs or people who engage in transactional sex, or remember that people comes first and think about what people need. Because if you can address what people need, then you really will make an impact on everything else along the line. I just want to end with the blue shed. So when we saw the blue shed initially, I was actually there with a colleague from whom I work with from Abbott, Gavin Cloherty, and the two of us were standing there by the blue shed. And we said, what do we turn this into a facility that could provide HIV testing, food, toilets, and everything for this population? Will there be an impact on HIV transmission in this community? So that was in 2017 or 2018. It took us only 5 years and a pandemic, but we actually opened the blue shed. So the original blue shed that I showed you no longer exists, but in true spirit of like having that blue shed, and we've been talking about this blue shed for 5 years, we actually found a space about 500 meters from where that original blue shed was. We established this facility and we're actually calling it the Blue Shed Project. The picture on the top right shows you the line of people who are waiting for opioid substitution therapy. So this is a joint project between the Delhi State AIDS Control Society, Abbott, Hopkins, which is providing some NIH funding, YRG Care, which is the local partner, multiple community-based organizations. And Christian can talk a little bit more about this once I'm done, about how we actually went about setting this facility. And and what has really happened since we opened this facility. So inside, we've also established a clinic, so the doctor examines patients. We also have access to antiretroviral therapy in here. Abbott have donated all the testing equipment. They've also donated an Architect IE1000, which allows you to do screening for multiple things. And we also have the chemistry analyzer. So we also want to start building in non-communicable diseases like renal function, diabetes, and things like this. But I think what was really striking was we were also able to provide food. So we were able to get funding to provide food to all these different individuals. We established showers, we established toilets on the site, and we've also got someone who can come and give you haircuts. And I think something that we don't realize is because we just take it for granted. We go get a haircut whenever we want. We go take a shower every day in the morning or at night, or sometimes twice a day. But it really is a luxury when you're working with populations in many resource limited settings who don't have that. And it's striking if you can go like a couple of days without having a shower or months without getting a haircut. There is something about it that makes you feel uncomfortable, right? And so these populations are living with it. So just by giving them access to these different services, we started attracting a lot more people to come into this facility. So we started this facility only about 20 days ago. We registered about 141 people, but you can just see that, and all these are newly diagnosed individuals. It's not being reconfirmed as positive, but just the positivity of HIV and hepatitis C and hepatitis B in this population is striking. We're now working on trying to get hepatitis B vaccination in here. So we're working with the Ministry of Health and Family Welfare in India to try and bring in Hep B vaccines. Because again, I think vaccine preventable diseases are something that everyone should be getting vaccinated for. But I think what really makes me happy is, besides providing all these services, which we were already providing, is we're also providing showers, toilets, and food for all these individuals. So I guess that is the last point I have for you, is never give up on a dream. I think 20 years ago, when I started working with people who inject drugs in Chennai, I think it was like Ramnath and Shruti and Greg, and when all of us were in Chennai, we said, the only way we're going to solve this problem is by building facilities that are going to provide multiple services besides for HIV. And I think my dream really still is to figure out how do we get them a skill, train them, and then reintroduce them into the communities. Because I think what happens many times is we get them on harm reduction services, but we don't change the environment in which they live. They still have no access to employment. And so it's like this vicious cycle of where they try to get clean, and then if something changes, they drop back. And so you really have to break that cycle. And the way you break that cycle is by intervening, right, and providing them with an opportunity for livelihood. But that being said, I think it's very easy to get carried away and overwhelmed because there are multiple things that need to do. And while this does look like we are doing something, there's just still so much more to do. And I think that's where Lakshmi really is coming to help us out, because I am not a pediatrician. I don't want to claim to be a pediatrician, but we're like, when we're working with people who inject drugs, it's almost too late. Right? How do you get them before they start injecting to prevent that hepatitis C infection, to prevent that HIV infection? And that really is the focus of what Lakshmi is doing. And many times I think about these different things, and it just gets overwhelming. So I always tell myself, like what my mother taught me, and I think that's a principle by which I live. And I think those of you who know the star thrower, this is an excerpt from the story where there's this old man who's walking down a beach. And it's the morning after a big storm. There are all these starfish that are washed up on the shore. And then in the distance, he sees a small boy picking up something and throwing it back into the water. So the man walks up to the small boy and looks at him and says, what are you doing? So he's like, oh, I'm throwing these starfish into the water because otherwise the sun is going to come up and they'll all die. And so the old man looks at the boy and says, but there are millions of starfish on here. I'm afraid you can't save all these starfish because most of them are going to die. And so the boy bent down, picked up another starfish, threw it into the water, and he looked at the man and said, at least it makes a difference to this one. And I think that's the way we really have to approach global health, is every person who comes into one of the facilities or one of the studies or something that we have, we need to make sure that they go out with a smile. Because there are going to be millions of people around the world where we are not able to impact, but that shouldn't overwhelm us. It really should be about improving outcomes among the people who come to us, and hope that that rolls into a larger impact and goes from that one small model to a larger model and just mushrooms to have an impact globally. I want to end by thanking all the research participants, my team from Hopkins, YRG Care, the National AIDS Control Organization, the State AIDS Control Societies, the multiple community-based organizations that we work with, all my funding sources. And I will turn it over to Lakshmi Ganapathy, who will probably add a little bit about the pediatric challenges in India. Lakshmi, over to you.
Thank you very much, Sunil. In the interest of time, I know we have 10 minutes, and Krish needs to offer a few words as well. So I'm just going to share a single slide, really. I think Sunil has offered some lens into really the scale of the services at this point in time in India. And has also offered a sense in terms of the epidemiology of India. I think the single point that I want to make really is that HIV incidence that Sunil has talked about quite extensively globally and in India is actually concentrated in young people. And these two graphs above here really illustrate this. This is from one of our cross-sectional studies done earlier in about 2015, which really illustrates that HIV incidence among those who are 18 to 24 years, particularly in regions where there are new overlapping burgeoning injection drug use and HIV epidemics, are really in the order of about 5%, which is extremely high. The graph here on the right actually shows HIV incidence among people who are coming to integrated care centers, and the purple line above that, above the light blue line, indicates the HIV incidence among people who are under the age of 29. And again, be it in the community or among people who are actually coming to get services, young people remain a vulnerable population among whom HIV incidence is concentrated. So I've really only provided data for those who are 18 and above, which begs the question, what about adolescents? And this is a big gap both in the global literature as well as in India. There are few, if any, size estimates of people who inject drugs who are under the age of 18. However, if you look at both global as well as national estimates in India, the median age of injection initiation is actually 19 years, which means that at least half of all people who inject drugs really are initiating injection in adolescence, but we're really getting to them pretty late. The other big gap really in terms of services is that adolescents do not start injecting immediately. There's really a period of non-injection opioid dependence. However, public sector services at this point in time in India are really limited to only those who inject drugs. And the other big gap really is that policy and structural barriers are a key determinant of engaging younger people who inject drugs. I actually put this newspaper clipping simply because it's really only the rough estimates that we have of adolescents who use opioids and inject opioids in parts of India. And this is from Punjab, a state in the Northwest, where recent estimates have suggests that there are at least 350,000 children between the ages of 10 to 17 who use opioids, including opioids like heroin. So I think at this point in time, a lot of our work, after we've scaled up all of these services, is really moving into the sphere of really thinking about differentiated care models. So how do we start implementing youth-centered interventions within existing service delivery models that Sunil and YRG Care and NACO have scaled up across India? And also, how do we really start thinking about just standalone youth-centered service delivery models? So I just wanted to talk about that sphere of work. And then I'll hand over to Krish, who really is our implementer extraordinaire, without whom none of this is possible.
And Krish, maybe if you want to answer the question about how do you think about caste and the tribal and migrant status, because I think you work a lot more with them. Like, how do you think about these when you're developing these programs in India?
Sure, Sunil. Thank you. I will want to start by saying it gives such immense satisfaction to be part of this team, actually, that we are able to cover such large ground. I'm going to switch off the video because I'm in a very unstable location for internet. So we start off working with many multiple studies, and we've been doing interventions, and like Sunil explained, that we are able to now offer comprehensive support to people. But I find immense satisfaction in doing a lot of ground beyond basic research at this point in time. But there's a significant amount of work to be accomplished still. It is truly gratifying to witness our evolution from mere researchers or providers of just care to where we stand at this point in time. The community goodwill that we enjoy across India is phenomenal. And just to give you the size of work that we do, we are at this point in time working in over 26 states in India out of the 33, and we have 900 live sites, which means 900 people, 900 sites where people from YRG are working, either in implementation research or program deliveries. So we work in also very diverse population at this point in time. We have like 21 sites that exclusively work with sexual minorities, that's transgendered individuals. We work with 35 locations across India that looks at migration. And to answer Sunil's question or to point, Delhi is a real mess at this point in time, or has ever been, because of the migration from adjoining states, and people move back and forth. Earlier they were moving for drugs, now they move for employment, or they move for social network basis. It's the answers we really don't have. And like Sunil said, the other bigger challenge for us is the opioid substitution therapy that's very, very suboptimal in India, with 50% retention, and the dosage that Lakshmi always grieves about in India's government is just not doing enough for that. But that's the national program. I will now stop here because I'm sure there are people wanting to ask some questions, and we are more than happy to respond. Thank you. Thanks for the opportunity.
Well, I want to jump in and say that that's really an incredible presentation with lots of very impressive work over the years that you all have obviously a lot to be proud of, and a lot to teach others about this model that you've built for care. I do want to encourage people to put some more questions in the chat. Here we have a question coming up about the person-centric framing that you talked about. So I'll read the question. It says, as you offer your services, building, organizing clinics and physical spaces, can you share if there has been involvement of the people who are accessing those services in the governance or the decision-making process or management, I think, of those clinics and services? So aside from doing research, how have you been able to kind of gain that person perspective in the management and decision-making? Great question.
Thanks, David, for that question. I think it's a twofold response. So I think the first thing is, like, for example, when we established our trans clinics across India, the entire clinic was staffed by people from the trans community, right? So from the doctor all the way to the outreach worker, they were all from the trans community. So there was this constant feedback happening. With the people who inject drug sites, we generally have people who are formally injecting, but not currently injecting. But again, it's one of those things where they're not currently injecting does not mean they're not injecting, or they will not inject again. So they have been involved in a lot of the establishment, but we also have these client satisfaction surveys, which goes out to everyone who comes into these clinics, and we get their regular feedback on what's working, what's not working, and how do you actually solve those problems. And I think I think that really is critical, and that's a great question. And I think getting feedback from them, that continuous monitoring is critical. In the northeastern states of India, where the PVID epidemic has been around for a much longer time, a lot of our staff are also are former people who injecting drugs, versus like in Delhi and Kanpur, just given like the young epidemic and the high levels of migration, we have fewer staff from the communities themselves. But that being said, we always build in their feedback, whether it's through governance or through client satisfaction surveys, because without their feedback, your models really aren't going to succeed.
I think one point to really answer the earlier question about the other determinants of health, like caste and tribal migrant status. One thing to note is that in the Northeast, it's really minority communities in India. And I think what Krish did not mention, which I'd like to highlight, which I really appreciate about the approach, is that Krish spends a lot of time meeting with the community even before we establish services in any of these locations. And so he gets community leaders and spends a lot of time in really building those relationships, even before you start doing any of this.
There are a couple more questions that are coming in the chat, and I hope we have time for all of them. But while we take a look at those, I also want to ask, you talked a little bit about how you've kind of developed this relationship as you were studying and working in Baltimore, which also has an opiate use epidemic for an injection drug use epidemic for many years, and as we've seen really across the US. that's the case. So I'm kind of interested in what lessons have you been able to translate from India back here to the United States? Have any of the lessons that you've learned over these years been directly translated or directly informed how injection drug use can be addressed here, either in Baltimore or in other parts of the US?
Sure, that's a great question. I think it's just the scale of resources that makes it a lot challenging to replicate everything that we've done in India back here. But I think the few things that we have been able to do is not just like, I think with respondent-driven sampling and network recruitment, that's something we've been doing a lot of in India. And a lot of that data has driven like other studies in the US, in Baltimore, which Greg Lucas has led, where we've used vans and gone out into the community and done integrated care from a van. So it's called the Integrated Care Van Study, which is built off like the Integrated Care Center study in India. And then there are other studies within the networks that have also used deep chain RDS to try and find populations. So things like that we have been able to do. But I think the things that we really want to do are like the more complicated ones, which are going to be a lot more expensive to replicate in the US. And I've tried proposing it several times. And the question is like, who's going to pay for this? So I think it's finding the right donors, because it's the same thing. Like I work in Baltimore, I've gone out on the vans, it's homelessness, food insecurity that are their big drivers. But there's less that we can do in Baltimore with the same amount of money than you can do in India. So we're hoping that if we can show that it works and show that it's cost effective and then, like, there is a return on investment by preventing new infections, and then maybe that model can be replicated in other settings globally.
You know, that's an interesting response, because it's essentially flipping our idea of resource limitations and saying, actually, well, the resource limitations can sometimes be on our end, or at least the motivation to invest resources appropriately might be on our end. Maybe we have time for one of these last questions. I see here a question about how you talk a lot about space. And if you could map this into a map of Delhi as it stands, what are the characteristics of the neighborhoods and the areas where you've been able to kind of implement these clinics and these services? Were there any surprising characteristics about the spaces that you've put into place?
For me, I think everything was surprising because we didn't think there was going to be one space that had such a big impact. It's actually just an open area along the banks of the Yamuna River. And I think what that space represents is, at least earlier in the day, it wasn't a lot of policing and anything else in that particular area. And so a lot of migrant workers who are coming to Delhi looking for a job from UP, Punjab, and other places, we're all like living in that place, right? So it was basically an open area that was providing resources, and there was access to harm reduction services, like I mentioned it, but it wasn't working to the extent, I think, as Lakshmi and Christian pointed out, is like many people all use buprenorphine, but they also end up injecting drugs at the same time. So I think that's sort of gives you like the sense of space, and like, each space is interesting. We don't know why people pick particular spaces. We're actually doing a bunch of focus groups and in-depth interviews right now to try and understand why people pick a particular place. And then when they switch from one place to another, why are they switching these places? Because I think that's something we still don't understand, is like, how are they picking these different places?
That's great. I think we have to end it right there, but I'm sure we have so much more that we could learn from you, and I want to just thank the three of you for such a really, really insightful and incredible presentation that lays a track of impressive work over the last 2 decades. So congratulations, and thank you again so much for joining us.
Thank you.